Okay, it's my pleasure to now introduce today's speakers. Dr. Martha Bilicki completed her Master's of Science in Genetic Counseling at the University of Toronto, followed by her Doctor of Medicine at the University of British Columbia. She completed her pediatric residency and pediatric emergency medicine fellowship at the University of Manitoba, where she now works in the Children's Hospital Emergency Department. In her spare time, she spends time with her dog Lucy and sings in a local choral ensemble. Dr. Rachel Kesselman completed her undergraduate studies at McGill University and her medical training, pediatric residency, and pediatric emergency medicine fellowship at the University of Manitoba. She now works here at the Children's Hospital Emergency Department. In her spare time, she enjoys getting outdoors, camping, and canoeing in the summer and cross-country skiing in the winter. We're delighted to have them both with us today, and I'll now turn it over to them to lead us through today's session. Thank you.
Thanks, Megan. I'm Martha Bilicki. Thanks for coming to this talk, and we appreciate being invited to give it. We're going to go over these general objectives. We're going to take you through some of the common emergency department presentations in patients with sickle cell disease. Those include fever, vaso-occlusive or pain crises, as well as acute chest syndrome. And then we'd also like to review some can't-miss emergency department presentations in these patients that include aplastic anemia, stroke, splenic sequestration, and priapism. This is a general disclosure that we've used in the past. We have a lot of people who support the work of TREKK. And neither Dr. Kesselman nor I have any conflicts of interest to declare. Just a quick high-level overview of sickle cell disease. It is the most common single gene disease worldwide with a prevalence of 1 in 4 to 5,000. And although it was originally found mainly in areas of the world with endemic malaria, increasingly a proportion of people with SCD now live outside of these areas. From some relatively recent Ontario Health Administrative data, we know that although most patients will interact with the health system in urban areas, patients with sickle cell disease have been found to present to health services in every regional health zone. We also know that the majority of these patients are presenting in childhood and young adulthood. This is an overview. Every black dot represents cases, and you can see that although they're concentrated around urban areas, they are distributed throughout the province of Ontario, and so it is relevant even if you work in a relatively out-of-the-way location. And this graph just shows the overabundance of presentations by age being in the young, adult, and childhood age groups.
So we'll start off with talking about fever. So infection is the most common cause of sickle disease-related mortality, as well as being a trigger for other complications of sickle cell disease, such as acute chest syndrome. We define fever as greater than 38 oral or 38.5 rectal, but really to keep it simple, anything greater than 38, whichever way they've taken it, I would consider as a fever. Part of the reason that fever is so concerning in sickle cell disease is that these kids are functionally asplenic, usually by the time they're 5 years old. So they're at a higher risk for other infections, such as those from encapsulated organisms like strep pneumo, Haemophilus, non-typhi salmonella. And so because of this, they should be having an extended spectrum of immunizations above their regular childhood immunizations, as well as antibiotic prophylaxis. And the other reason that it's such a kind of high level topic is that anyone who sees kids knows that fever comes so commonly. You'll see, every child present very commonly with fever, but needs to be treated a little bit differently in sickle cell disease. So those with fever require prompt assessment, prompt investigations, and prompt start of antibiotics. So for anyone coming in with a fever, they should have a blood culture done, a CBC with a reticulocyte count, a total indirect bili, a type-in screen in case they're needing a transfusion. For those under 3 years old, strongly consider a urine culture where a UTI is going to be more likely. And your other investigation should be based on their presentation. So there should be a low threshold to do a chest x-ray, a low threshold to do something like an NPA to look for viruses, mainly because that can help our management later on if we're able to identify that it was a virus causing the fever. Parental antibiotics should be started in every single child with a fever, even if you think that this is due to a virus, a second or third generation cephalosporin, and if they're allergic, then clindamycin or ciprofloxacin. In terms of your management after that, the big question is who needs to be admitted or transferred to another center and who can be discharged home. So some of these are easy. Anyone who looks very unwell, they're hemodynamically unstable, they look septic, they're in respiratory distress, any severe illness, those absolutely need to be admitted or transferred to another center. But some that you might not think about are the very young patients who might have more complicated courses, those who just have a previous history of a severe illness, those with significant blood work abnormalities, and then those who also have severe pain that can't be managed at home. And then the one thing I would really highlight is anyone that can't have close follow-up needs to be admitted or transferred if there isn't a way for them to have outpatient follow-up. So in terms of outpatient management and who can be managed as an outpatient, anyone who doesn't meet those above high-risk criteria can be discharged home after they've received 1 dose of ceftriaxone, with arrangements made to get a second dose of ceftriaxone 24 hours later. So in our emergency department, that means bringing them back the next day for clinical reassessment and a second dose of antibiotics, and then seeing them even one more time at that 48-hour mark to make sure that their blood cultures aren't positive and that they are clinically well before discharging them home. If there's a source of infection, you can stop there or continue antibiotics for that particular source. And this is where that NPA can be helpful, that if it comes back positive in these 48 hours and we know their fever is from a virus, then it may be easier to stop that antibiotic. Everybody should receive ceftriaxone and follow up for 48 hours, even if we do think this is a viral illness, because they're at such higher risk for infection and for more severe illness.
Moving on to the second most common, or at least equally most common reason for presenting patients arriving in the emergency department. They're at risk of vaso-occlusive crises, which essentially cause pain. So in the common vernacular, they'll refer to these issues as pain crises. Pain is the most common reason for admission in patients with sickle cell disease, and there are multiple triggers for these episodes, including dehydration, other illnesses, or even fever, as well as postoperatively. They certainly can also experience pain in response to cold exposure, which we mention specifically because typically we offer people in pain cold packs in certain circumstances, and in these patients, we actually should avoid that. And then other sources of stress. One of the important things to highlight is their objective presentation to you may not be in keeping with what you would consider to be typical pain symptoms, even when experiencing severe pain. In addition, if patients with sickle cell disease present with pain, there are a number of specific painful conditions to consider that you might not otherwise consider. So there's all of the regular causes of pain. So, appendicitis, abdominal cramping, broken bones, etc. But then you also need to consider specific conditions such as splenic sequestration, which often causes abdominal pain, dactylitis, which is a specific complication involving the digits of individuals with sickle cell disease and typically presents in young children, osteomyelitis, which because of their relative immunocompromise, they have an increased risk for, as well as acute vascular necrosis, acute chest syndrome, and stroke. Even in light of that, uncomplicated vaso-occlusive episodes generally do not require extensive investigations. I will again highlight you should have a relatively low threshold to consider a chest x-ray in patients if there's any element of tachypnea or chest pain because of the relationship with acute chest syndrome. And again, don't forget to consider all of the regular reasons that you think about, all the regular causes that you think about with patients in pain. One of the things to highlight is that in these vaso-occlusive episodes, prompt and multimodal pain control should be administered. We recommend scheduling acetaminophen and like as long as you're happy with renal function and other things, scheduled anti-inflammatories such as ibuprofen. In moderate to severe pain, we should be rapidly administering opiates or opioids. You may consider oral opiates or opioids. Many of these children will have those prescriptions at home by the time they've had a few pain crises, but if this is their first ever, they may not have that prescription, and it might be nice to know that they would be appropriate for discharge if we can establish good pain control with that. But if you're wondering about moderate to severe pain, consider your parenteral routes, so your intravenous, intranasal, or subcutaneous routes for administering these medications. And it's also important to highlight that in general, higher doses are required for these patients compared to other pediatric populations, both because they tend to be non-opiate naive, as well as just in general, I think traditionally the literature would suggest these patients are undertreated, so you should start a little higher than maybe you would normally. Multimodal pain control is particularly of a concern. There's this really great multiple page document that reviews some of the key management strategies. I've put the link in here. But we certainly want to be offering warm packs or warm blankets, caregiver massage, as well as comfortable positioning. But again, highlighting we want to avoid ice packs and other cold packs. Many families know what works for their children, and it's particularly important in this condition to ask what typically works for them: distraction, guided relaxation, age-appropriate games, tools, other things like that. But these should all be used together with pharmacologic management, and we want to prioritize prompt administration. Just as with antibiotics in children with fever, we want to be promptly managing these children's pain. One of the reasons for the focus on this is there is extensive research that has been done over the years to show that emergency department physicians often have negative perceptions of sickle cell disease patients in general. They're over-predicted to be addicted to opioids. They're assumed to be exaggerating their pain, and often are described in terms like dishonest, uncooperative, manipulative, and frustrating. And I will say that although 2 to 5% of the population of patients with sickle cell disease meets the diagnosis for opioid addiction, that is similar to the general population. And emergency physicians studied in one of these studies predicted that greater than 10% of these patients would have that addiction. So it's important to be mindful of your own biases and assume that the patients are being honest with you about their degree of pain, regardless of the way they present to you, because these diagnoses of sort of secondary gain or opioid addiction or drug seeking are not things we should be making as diagnoses acutely in their emergency department presentation. Additional management for these types of episodes, we like to encourage oral hydration. Historically, it was often thought they needed high amounts of IV fluids or boluses. In general, from our perspective, if they appear to be clinically dehydrated or are unable to tolerate oral fluids, by all means, use your IV fluids, but otherwise they should be able to drink to keep themselves hydrated. And again, applying supplemental oxygen only as needed to maintain their oxygen saturations, not specifically to prevent worsening of the pain crisis that they already have. The last point on these pain crises is we want to encourage early and regular reassessments of the analgesic effect so that we can appropriately titrate medications. This becomes more important the more severe their pain is. Certainly, these patients may be discharged home if we get good control of their pain and they're tolerating it well with oral medication, and the family has access to that medication. They certainly should have some type of close follow-up with a practitioner who knows about their condition and can help them manage it. If the plan is to admit for ongoing analgesia, I would recommend consulting the pediatric hematologist and making arrangements for transfer to whatever local pediatric referral center you would use.
Okay. So moving on to acute chest syndrome, which is our third kind of more common emergency department presentation. Oh. So acute chest syndrome is a potentially life-threatening complication, and it's the leading cause of morbidity, although it is a little bit less common than vaso-occlusive crisis or fever. Both of those can also lead to acute chest syndrome. It's important to note that it's more common in children than in adults, and that it overlaps with other common childhood illnesses. So, children with asthma and sickle cell disease are 2 times more likely to develop acute chest syndrome compared to those with sickle cell disease alone. And symptoms overlap with both asthma and LRTI. So, it's not necessarily that you're diagnosing one independently of the other. Both of those can still cause an acute chest syndrome. So to meet criteria for diagnosis, you need a chest x-ray that shows a new pulmonary infiltrate involving one or more lung segments, so essentially something new on their x-ray compared to previous, as well as fever and any respiratory symptoms. So that can be cough, wheeze, increased work of breathing, chest pain, low oxygen saturation. So any one of those in combination with a new pulmonary infiltrate would meet the diagnosis of acute chest syndrome, which is why you can have pneumonia and acute chest syndrome or asthma and acute chest syndrome. Pulse oximetry should be done for all patients with sickle cell disease to screen for acute chest syndrome, because if it is low or abnormal at all, then chest x-ray should be done. And patients with fever and with vaso-occlusive crisis should be assessed and frequently reassessed to detect acute chest syndrome early. So meaning that when they come in with fever or pain crisis, part of that management is trying to prevent acute chest syndrome and keeping it in the back of your mind while you're treating them that they may develop that throughout their stay. So just because they didn't have it at the beginning doesn't mean that they won't necessarily develop it. Management is mainly supportive, so applying oxygen to maintain saturations greater than 95%. If they are already maintaining their saturations, you don't need to apply extra supplemental oxygen. Treating symptoms, so in a patient with asthma who is wheezing, still treating their asthma, considering bronchodilators. All patients should get antibiotics, so again, a second or third generation cephalosporin. In teenagers or those with bilateral infiltrates, you may also consider adding something on like azithromycin to treat your atypical bacteria. Um, Similar to vaso-occlusive episodes, it used to be thought that we need to overhydrate, but really we want to maintain euvolemia. So not every patient needs IV fluids. If they're able to maintain hydration drinking, that's great. IV fluids only if we're having dehydration. We know now that overhydration is actually associated with worsening acute chest syndrome. Again, aggressively managing their pain so they don't develop a pain crisis, but making sure to avoid oversedation as that will worsen their acute chest syndrome or cause an acute chest syndrome if they didn't have one to begin with. And all of these patients should be discussed with, depending where you work, pediatrics, your referral center, or pediatric hematology, because every patient with acute chest syndrome needs to be admitted to hospital.
One of the other complications that we just want to highlight is that these children are much more likely to develop aplastic anemia than children without sickle cell disease. Many viral illnesses do cause transient red cell aplasia, which for the average child might be completely manageable, but in a patient with sickle cell disease can cause a severe acute anemia. In particular, parvovirus B19 or Fisk disease is a particular trigger. Symptoms of aplastic anemia can include fever, pain, headache, fatigue, and pallor. And your investigations, which you will typically have ordered for one of those reasons, will reveal severe anemia and a low reticulocyte count. The illness is usually self-limited, but in these patients, they may actually require transfusion. Go ahead, Rachel.
Another important complication that we want to highlight is stroke. So while very uncommon in children, sickle cell disease is the most common cause of stroke in children. So while it's not often something we're thinking of, it should be thought of in those with sickle cell for any new neurologic deficit. And that can be quite broad. So headache would be considered a new neurologic deficit. Even with someone with a history of headache or migraines, still need to consider a stroke. Is this headache different at all than their usual presentation? And I would have a very low threshold to still discuss it with um, hematology and neurology. But other things like weakness, abnormal speech, seizures, gait abnormalities, any focal neurologic deficits, and in younger patients, even a change in behavior. So being, more lethargic than usual, not feeding well, anything that parents identify as different than normal would be a low threshold to consider stroke. Um, Even if it seems like there may be another good cause for their presentation, you still need to consider stroke. So, for example, there was unfortunately a few years ago a patient who was seen with a facial droop and was diagnosed with a Bell's palsy. They did not improve with treatment and unfortunately later were diagnosed with a stroke. So even though there may be some other explanation plausible for their deficit, stroke still needs to be at the top of your differential to be ruled out. In terms of management, again, supplemental oxygen is needed. Encouraging oral hydration or IV hydration is needed without overhydration. Maintaining a normal temperature, normal blood pressure, normal glucose, seizure control, all essentially with urgent consultation to hematology and to pediatric neurology. If CT is available, then you can certainly start with a CT in your center as a first test, but even if negative, they still need an MRI and an MRA to rule out stroke. And CT shouldn't delay transport, as we know, regardless, we're going to need that MRI, MRA. So first discussing with hematology and neurology, and then deciding where the next imaging and the next investigation should take place. And again, ultimately, all of these patients are going to need to go to your nearest pediatric referral center after discussing with hematology and neurology.
Okay, one of the other sort of unusual aspects of sickle cell disease that may not be on people's top of mind is splenic sequestration. This is one of the first serious complications of sickle cell disease and typically presents before the age of 5, because generally by the time the children are 5, they really don't have splenic function due to auto infarction. So these children on average are less than 18, are on average are about 18 months when they present with this. Symptomatically, they'll often present in shock, so weak, pale, with tachycardia and tachypnea. They often will have left upper quadrant pain, back or left-sided flank pain, and they may even have chest pain. And they often will present with fairly significant splenomegaly. So in general, palpation of the spleen should be performed in all patients presenting with this type of symptomatology. And often the parents themselves have been taught how to do this and can tell you where they usually expect to find their spleen tip. The diagnosis can be made when there's a newly enlarged or enlarging spleen size, especially if there's an associated drop in hemoglobin. And again, many patients' parents will be able to tell you what the typical hemoglobin is that they expect for their child. Prompt investigations for these patients include a CBC with a reticulocyte count and a blood type and screen, and these require urgent consultation to pediatric hematology or your pediatric referral center. Often these are abrupt onset conditions and there won't be much prodrome before these patients. So it's important to think about.
And then the last presentation we wanted to draw your attention to is priapism. So again, not common, but more common in those with sickle cell disease. So priapism is any prolonged erection unrelated to sexual stimuli. And sickle cell is the most common cause in children. There is a bimodal presentation, so often those younger kind of preteen kids around 7 to 10 years old, and then a second in older in adults, so 20 to 50 years old, but quite uncommon in age groups younger than 7 years old. It is often more of a stuttering priapism, meaning that they'll get recurrent episodes of prolonged but self-limited priapism. So they may have it for a few hours and then it goes away and then comes back and then goes away. So it's not necessarily there the entire time. When assessing these children, we want to ask about the onset of erection, if they have pain, the severity of pain, if there were any precipitating events, and then kind of about that stuttering. So has it been there the whole time or has it been off and on so that you're not hearing only about the last episode? Principles of management, IV hydration, analgesia for pain, again, oxygen to maintain SATs greater than 95%. But essentially, this is a surgical emergency, so pediatric urology should be consulted early for all of these patients to help guide management. There's a few different options for management, but again, all of those should be discussed with pediatric urology.
Go ahead, Rachel.
Lots and lots of information in this talk. Our goal was kind of just to touch on those most common topics and then some uncommon things that you might see not to forget about. But all of this is summarized in the bottom line recommendation on the TREKK website. It's a little bit lengthier than some of theirs just because there is quite a bit of information in it. And we're reassessing it at the moment to try to include all this information, but also put a focus on what all of those initial management steps should be. There's also a bit of extra information that we didn't talk about here. So things like dosing of antibiotics, what antibiotics to choose for various clinical scenarios, some suggestions for pain management, both with the sort of multimodal non-pharmacologic options, as well as some dosing guidelines for your pharmacologic options for those who don't use them as often in kids. So we are working on revamping that, but there is one currently out as well. So just going over briefly kind of our goals in the first 60 minutes. So rapid initiation of pain management with very frequent reassessments. We really want to focus on engaging patients and families to help strategize, as they often have the best sense of what has worked in the past, what they've already tried at home and what optimal next steps might be. Rapidly titrating analgesia and ensuring that we're using multimodal pain management strategies. And remembering that anyone with abdominal pain should be assessed for possible splenic sequestration, which can lead to shock quite rapidly. And then all febrile patients should be assessed and receive antibiotics within the first 30 to 60 minutes of arrival.
Other things to think about that we don't often think about in the pediatric emergency department include incentive spirometry. It can help reduce the likelihood of developing acute chest syndrome. And just again, in most patients with most presentations, if there's something that potentially is related to the chest, send them for a chest x-ray. And then just have a low threshold to consider neurologic deficits, including a new or unusual headache for possible stroke. These are the kinds of conditions we don't want to miss, and so these should be urgently discussed with hematology or neurology. Overall, at the end of the day, our major bottom line is virtually any case of a patient with sickle cell disease. If you are feeling uncomfortable with the potential management or the potential implications of what they're presenting to you for, have a low threshold to contact your specialist that you would like to discuss the case with, because a lot of these patients do end up getting transferred to the local referral centers. All right, with about 20 to 30 minutes left for questions. We'd like to thank you for your attention, and there's some general guidelines if you want to look at references, and we're happy. I see some comments have appeared in the chat. We're happy to take the questions that have come so far and may come further forward.